Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is entitled Creating Safe Spaces in Healthcare for People Who Use Drugs. This session is being recorded for nurses who are unable to participate today. My name is Carrie Schuhendler, and I'm a registered nurse and policy advisor at the Canadian Nurses Association, and I will be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type into the Q&A box that you'll see to the right of the slide. We will address as many questions as time allows. And now, a little about our presenters, Dr. Pauly and Jill Carter. Dr. Pauly is a registered nurse and associate professor in the School of Nursing at the University of Victoria. Her program of research is focused on health equity, substance use, and harm reduction. She has worked collaboratively with peer-run organizations of people who use drugs for 10 years and is currently a board member of the Society of Living Illicit Drug Users, or SOLID. She has conducted research on cultural safety in healthcare, and her work has informed regional, provincial, and national policy on health equity, substance use, and harm reduction. Jill Carter is a published poet, accomplished public speaker, and a group facilitator. She is currently Secretary-Treasurer of the Society of Living Illicit Drug Users, or SOLID, and a long-standing member of its board of directors. SOLID, located in Victoria, B.C., is a peer-run organization dedicated to improving the lives and well-being of people who use drugs. Jill is committed to ending stigma faced by people who use drugs. This webinar is the fourth in the series about substance use trends in Canada. And now I'll hand it over to Dr. Pauly.
Good morning. Since we're meeting in a variety of locations, I want to start by acknowledging all of the people of the traditional territories, as well as all the treaty peoples and unceded territories that are represented in all of our locations, and that might be represented in the discussion that we have today. It's a great opportunity to be with you, and I wanted to share with you that Jill is not able to be online in person today. She's actually on a medical leave, but she asked that her comments that she wanted to make today be shared with you. This is an issue that Jill has cared about deeply for a long time and has actively worked to reduce some of the stigma that people who use drugs face when they access health care. So I want to start the conversation with a few comments about why people use substances. Then I'm going to share with you some of Jill's experiences in her own words, and then share with you findings from a research project that myself, Jane McCall, Annette Brown, and Joe Parker conducted collaboratively with people who use drugs, and particularly with SOLID. So why people use substances, I think we need to start our conversation at a place that helps us to think about substance use as a feature of society. And substance use, it may refer to all types of substances, both legal, such as alcohol, and illegal or illicit, such as heroin, cocaine, crack, and other types of illicit substances. And people use substances for a variety of reasons, and you'll see four of them there on the slide. It may be to feel good, to enhance feelings of well-being, confidence, more energy. You can sort of think of, drinking coffee or taking an energy drink or some other type of stimulant to stay awake when we're studying for exams. People may use substances to feel better, to reduce social anxiety, very common use of alcohol, particularly among young people, to develop relationships, but also to reduce symptoms that are associated with trauma and stress. And we can think about this in that substances are often used in ways that are a response to things like abuse, historical trauma, to deal with and cope with very difficult situations as well. They can be to do better, so to increase our performance, and also as a way of of experimenting or trying new substances as part of experiences. So the point is that substance use is a feature of our society. However, substance use, and particularly when it intersects with issues like poverty and homelessness, or issues of other types of stigma and discrimination, is often highly stigmatized. I'm just trying to get it to go to the next slide. Oh, there we go. I just want to follow that when we to recognize what is currently happening in Canada. We are in a crisis of overdose emergencies. This is not simply a crisis of addiction. It is a crisis of overdose, as overdose can affect anyone who uses a type of illicit substances that may have overdose as a harm. And so I think we need to remember that while substance use is a feature of society, overdose can affect anyone who uses a type of illicit substances, regardless of their particular social position. And so a few weeks ago, less than 2 weeks ago, I was in Montreal for the International Harm Reduction Conference on May 14th, the Minister of Health spoke about the current crisis. And while many acknowledged that Canada has been making gains in reversing very regressive harm reduction policy, harm reduction during the previous government had been removed as a pillar, that many of the actions that the current government is taking to try to make it easier to establish supervised consumption sites, to make naloxone and Suboxone more freely available to people across the country, these changes are happening very slowly at the time when many, many people are dying. And to put it into context, probably in 2016, more than 2,000 people died of an overdose, and our data on this is pretty limited, so those numbers are complete underestimates. That's probably more people than died per year during the first 30 years of the HIV crisis. And we are at the beginning of this. You'll see on the left some very straightforward and simple solutions that were put forward by the Canadian Association of People Who Use Drugs in order to immediately stem the tide of overdose deaths, to open supervised consumption sites immediately across Canada. And we have seen some announcements last week in terms of new sites being opened in several cities. I live in Victoria, and while we've submitted our application, we have not received approval yet to continue. To immediately increase widespread use to opioid treatment, including diacetylmorphine and hydromorph, which are can be used for opiate use disorder, increase funding to grassroots harm reduction services. And I can tell you that those services, like the services that Solid provides, are the ones that immediately reach out to people who are being disproportionately affected in this crisis. And to prioritize the leadership of people who use drugs as key stakeholders in progressive drug policy change and fund user groups so we can advocate for ourselves. And I think the voice at the International Harm Reduction Conference, the voice of user groups was so important to identifying what was happening on the ground and what else needs to be done. And to decriminalize the lives of people who use drugs by legalizing and regulating all drugs. And that is a system change which is one that it becomes clear in an overdose crisis is desperately needed, to decriminalize all substances and begin to regulate them, because the source of the problem is in an unsafe drug supply. However, given the current drug policy that we have, there are many harms associated with our current drug policy, and one of those key harms is stigma. And I want to share with you some of the comments that Jill so wanted to share with you today. She's She's currently on medical leave, and up until yesterday, she had really, really hoped that she would be able to be here with you, and she told me yesterday how much she wanted to be there, but was very wanted me to present her comments on her behalf. And so what I'm going to read is some from her notes and share with you some of her experiences. And I'll be speaking in the first person, but in no way can I capture exactly the way that Jill would say it or do it. But one of the things she said to me is, she said, "Bernie," she said, "you know me very well, and I know that you will present these things to the best of your ability. So I'm going to try to live up to Jill's confidence in me." We've worked together for about 10 years on many different projects, including the one I'm going to talk to you in a few minutes. So here's what Jill prepared. "I worked for many years in a hospital, but was laid off due to cutbacks in healthcare. Shortly after I got my layoff notice, someone broke into my home and assaulted me. I called 911, but the police did not call an ambulance or help me at all, and even threatened to charge me because there was drug paraphernalia in my house. This paraphernalia was not mine. It belonged to the person who had assaulted me. Needless to say, the attitude and behavior of the police was re-traumatizing in a situation where I had already been traumatized. I and other people with the same experience often do not feel safe to call 911 because of the way we've been treated, fearful that will happen again, and afraid of the same thing happening to them. Like many people who are homeless, I had difficulty accessing health care and faced a lot of judgments when accessing hospital care. At one point, I went to a doctor who told me on the phone he was accepting new patients. But when I arrived, he took one look at me and said, "I can't accept you as a patient. You have too many problems." He made this decision in less than a minute in the waiting room without even a physical exam. People are often refused care. They're often refused care because of the way they look or when their urine tests positive for drugs. It feels like you have to lie about your drug use in order to get help, and it's extremely difficult to get care when you have a history of drug use. If you tell the truth, you will not be able to get the care you need. In order to get equitable care, honesty is not the best policy. Even today, I don't feel comfortable telling the truth about my history with drug use for fear of how I will be treated or how I will be denied care. When a healthcare provider asks me a question about drug use, I begin to get anxious. I know that how I answer that question will affect my care and determine how I will be treated. Recently, I had to have a procedure, a dental procedure to remove all my teeth. Normally this is a procedure for which you're put under. However, because I'm on disability, this is not covered. So I received additional pain medication for the procedure. And because I experience anxiety, pain meds metabolize quicker, and I require more medication for anxiety and pain. So in that situation, if you put down a history of drug use, you would be prescribed less medication than other people for the same procedure, when in fact you should receive more. People are dying without proper care. Patients in pain are accused of being drug-seeking. What healthcare providers often don't realize is that by refusing people painkillers, they are pushing them to be drug-seeking, to deal with pain and seek out illicit drugs that are killing people. In the current overdose crisis, this is potentially deadly. People in pain should not be denied pain medication. Everyone should have the basic human rights of access to health care. Who you are should not matter when it comes to receiving health care. I, along with other members of SOLID, have had many experiences with being denied health care, unable to access health care for fear of mistreatment, and many negative experiences in the healthcare system. Reducing stigma in healthcare is important and a priority for me and for all members of SOLID. I'm passionate about these issues and want to play a role in taking action to make changes that will benefit other people who use or have used substances, who are afraid to access health care and afraid of being truthful because of how they may be treated or treated poorly, even if they don't use drugs and are suspected of using drugs. I'm committed to ending the stigma faced by people who use drugs and believe that by working together we can change things in our society and continue to work in identifying the complex roles of both allies and peers to enable us to make those changes. I believe that meaningful dialogue and educating the community about stigma faced by people who use drugs and clarifying myths and misperceptions about illicit drug use can help reduce stigma. I think Jill, and I'm just going to stop there, Jill's shared several of her experiences, and I wish she had been here to share them with you, but I think, they illustrate how stigmatized drug use is in our society and how it's disproportionately borne by some people more than others, in spite of the fact that drug use occurs all across society. So in working with Solid for many years and doing my own research around access to health care for people that are street involved, I identified with this issue of the difficulties that people who use drugs have in accessing health care. And through a number of years, I had been working with registered nurses at Insight to identify how their practice was consistent with professional and ethical standards of care, because you can think back to probably about 7 or 8 years ago when there was a lot of controversy around Insight and challenges related to the practice that was occurring there. And so as I was working with nurses at Insight, they identified in describing their model of professional care that cultural safety was an important part of their approach. They had adopted cultural safety as part of their model of care because there had been many of their clients were Aboriginal. But what they identified is that while they implemented principles of cultural safety because they wanted to improve care for their Indigenous clients, they found that it was a useful approach for working with all of the clients that they cared for. So I just want to give you a little bit of background on cultural safety and then describe to you some findings from a research project that we conducted on creating safety in care for people who use drugs. Cultural safety is a framework for nursing practice, or for healthcare practice actually, developed by nurses in New Zealand. And it was developed in response to the healthcare needs of the Maori people to address culturally inappropriate and insensitive care in the system. Importantly, cultural safety is defined by the people who are accessing care, and it requires that the healthcare provider recognize their own position of privilege and their own location within the healthcare system, and that how they and how the system may be influencing care that is demeaning and diminishing. And there's quite a lot of good literature written by Ramsden on cultural safety, and I'd be happy to provide references more. And many will be familiar likely with cultural safety as it's been adopted in Canada by many Indigenous organizations. So in our research, what we wanted to know was 3 things. We asked the question, what is culturally safe nursing care in acute care settings for people who use illicit drugs and face multiple social disadvantages? What are the similarities and differences in how people who use drugs and nurses view culturally safe nursing care? And what are the necessary elements of practice environments that promote culturally safe nursing care? We used an overarching collaborative research design, and so the first thing we did is we established a nurse advisory, which was composed of nurses in the hospital where we conducted the study, and also we brought together a peer advisory, which was composed of groups from members of Solid Society of Living Illicit Drug Users. We first conducted nurse interviews and analyzed them. and took those findings back to the advisories, who provided us with excellent insights in how to interpret some of those findings. We then interviewed patients who were currently receiving care in a hospital setting and identified as someone who used drugs and experiencing some type of social disadvantage, such as poverty and homelessness, living on a low income, and again returned to the advisories for their interpretation. At the end of the project, we had several policy forums where we brought together a broader group of both staff and other people who identified as people who use drugs. And I recall very well one of the people who attended on behalf of people who use drugs who said this is a really important conversation and it's long overdue. And I'm going to tell you a bit more about that conversation as we go on. Here's a picture of Solid, who was the peer advisory for this project, and you can see on your right-hand side, far right-hand side, Jill is there on the advisory. And we had a consistent group of 10 people drawn from members of Solid who acted as advisors on this project and throughout the project and helped produce the guidelines that we'll share for you at the end. And I recall well one of the men on the project, he'd say, I don't always remember what this project is about, but I know that it's really important. And I think although you know, in community-based research, we often think of the issue being identified by the community. It was very clear from my experience and from what I had learned from Solid that this issue of access to health care and addressing stigma are critically important. So what did we find out? The first thing that people brought forward repeatedly was the kinds of ways that substance use is often framed and often highly stigmatized when people go to access health care. It's often framed as an individual problem in which people who use drugs feel that they are being blamed or judged as an addict. And I think from the nurse's perspective, there were definitely nurses who held that view that drug use was an individual responsibility. But importantly, there were nurses who understood that drug use is a response, that drug use can be a response to trauma, to pain, to anxiety, to stress, and who recognized that systemic processes had actually created social circumstances in which people were coping with substances as opposed to being a moral failing or at fault for substance use. Secondly, people identified that drug use is often criminalized when they enter healthcare, and that was experienced in a variety of ways by patients. They often described feeling under surveillance, and they felt like people were watching them. And in one example, one of the participants indicated that, you know, something had gone missing on the unit. There had been, someone had lost something and felt that, you know, they came and searched his belongings, and they felt that, you know, he felt that he was being targeted because they did the search like several times. And of course, he did not have what they were looking for. It had been misplaced, but you know, he felt immediately the gaze was upon him. And so people often felt when nurses were asking, you know, where are you going? What are you doing? Even though they were not intending to, it felt to patients like they were under surveillance. And what both patients and nurses brought forward and recognized is that where this comes from is our current policy, which has made some drugs illegal, not on the basis of any kind of pharmacology, but more so on the basis of morality. And if you look at the history of drug policy, you'll see how those decisions were made. Thirdly, patients and nurses both identified that substance use was often medicalized and described as a disease of addiction. And while that was meant to be a more compassionate, understanding response to frame things, and currently you'll hear a lot of description of, the chronic relapsing disease of addiction, addiction as a brain disease, as an example of a kind of discourse in healthcare. When that's put together with taking away people's decision-making capacity and painting them as out-of-control victims is also stigmatizing people and highlighting highlighting deficits as opposed to the many strengths that people have. And so this is all very, these three discourses are outlined in a paper that we published together in 2015. What I want to move to next is what's required for creating safe spaces for people who use drugs in healthcare. And I want to share with you 3 points that emerged from our research. The importance of recognizing the trust gap, the ability to bridge the trust gap, and to build a climate of trust in which unsafe policies and practice in healthcare are challenged. So recognizing the trust gap. As part of cultural safety, it often begins with the practitioner recognizing not only their position, but their ability to recognize stigma and stereotypes in healthcare around drug use, to recognize power imbalances, and to recognize that when people may be upset or angry, it's not necessarily about you as the nurse. And I think we all learned this kind of early in our career that, when people are in pain, when they're upset, when they're concerned, and when they're upset at you, it's really not about you. But I think in the situation when we're dealing with people who often feel highly marginalized and stigmatized, it's important to recognize that there's often a gap in trust. And that gap in trust is because trust, as one participant said in an earlier study I did, trust is a lousy survival tactic. You have to be very wary when you're on the street as to who's around you in order to stay safe. And so when people come into hospital, it cannot be assumed that trust will be there. Trust must be earned. And, the other feature that erodes trust is some of the negative experiences that people have had in many different systems, whether it's child welfare systems or healthcare systems, criminal justice systems, that it is very difficult to trust when you enter large institutions like hospitals. People who use drugs in this study identified that they wanted to be treated with respect, the same respect as others receiving care. And I can tell you, and you'll see this throughout, that trust, that respect is really critical to achieving and earning trust. This is a quote from one of the nurses in the studies who says, "The whole thing that motivates me is to maybe plant a seed of safety, of trust. Because a large proportion of our patients have a really hard time trusting people. It's really hard for them to access any kind of treatment or services. So I try really hard, to establish some kind of safety. And, I don't really think our patients need any more people judging them." And she also highlighted that oftentimes she worked in a unit where they were providing care, particularly for people who use substances. It was an area that they had expertise in and wanted to, further develop their expertise in, which is why they participated in this research study. And she identified that, yes, some people sometimes did leave without care, but when they came back, she felt that it was really important to welcome them back and to make them feel safe, which is what she's talking to in this quote here. So recognizing the trust gap and then bridging the trust gap. And I'm just going to share with you first what patients described and then what nurses shared in terms of what helps to bridge that gap in trust. Patients described 5 things: being given space and that nurses, and that they felt that nurses trusted them. When nurses took their concerns seriously, and when they did little things that to you and I might not seem that big, were huge. And here's just a description of that, some of those little things that patients thought were really important. They'll take a couple of extra minutes and, see that you're okay, and, they'll fluff your bed or something or other. Let me grab a blanket. Or, are you sure you don't need something for pain? You can tell by even just their voice that there's genuine concern. And so those small things and the tone of voice really mattered to people in this study. They also identified that when nurses explain things, and they weren't asking for nurses to necessarily do anything different than they would do for other people, but when they would explain to them and say, well, we have this test book for you. I know that, you need to, do something, but here's kind of the situation, and I really don't want you to miss your test, or explaining why a particular test was important, and explaining things in kind of a direct, straightforward, honest way was really important. People also identified that when nurses did not rush, that made them feel much safer. So they didn't sort of breeze in and breeze out. And I recognize, and we all recognize, the time pressures. But I think it isn't even so much the amount of time, it's the demeanor, it's the attitude that one enters the room with. Because when people are rushing, it often makes people feel like they're being brushed off. And so when you are often brushed off, it's just magnified in these situations. And so people start to feel uncomfortable, and that often contributes to them leaving hospital early before they can complete their care as well. And so these were things that patients identified that nurses could do that would help to increase respect and build trust. For nurses, they said it was also important to bridge the trust gap, but they talked about it in different ways. They talked about the importance of reframing goals and expectations, and they talked about shifting from, focusing less maybe on particular aspects of the clinical care and more onto and emphasize the building of trust and the building of emphasizing the importance of building the relationship. So putting those things first, respect, building trust, and then much more able to provide the clinical care within that. And so focusing on building a positive therapeutic relations as that was more likely for people to stay and complete their care. So they kind of had to shift where their priorities are, and again, recognizing those aren't always the priorities in healthcare. We also looked at what was in, and remember, the units that we were working with had a particular commitment to serve people who use drugs, and so we asked questions of both the patients and nurses about what supported creating safe spaces. And so clearly the commitment of the organization to serve people who use drugs was really important, because nurses knew that was a priority of the organization, and particularly it was a high priority and commitment on their unit. They said that having harm reduction as a philosophy was really important, but one thing we discovered was that the harm reduction policies were not always clear, and I'll tell you a bit more about those in a minute. Nurses identified resources that supported good care in their environment, and so when they had access to other types of teams, and particularly addictions team to provide additional care to people, was very helpful. And many nurses identified that they had taken a continuing education course in substance use and addiction, which was also very helpful to them. However, some of these things that made it easier were often missing, and so made it harder to provide and create culturally safe care. So a lack of formal training in substance use and addictions, and many said that they have very limited opportunities. Unclear and conflicting policies related to drug use and harm reduction in hospital. And there were, while this unit had clear harm reduction philosophy, and they espoused that, we actually, when we asked the nurses, they said, well, yes, we think we have policies on harm reduction, but as I'll highlight for you again in a minute, we could not find those policies. High staff turnover in diverse patient groups. This makes, obviously, it very difficult for nurses to provide, and often evaluations based on who's most worthy and deserving, as opposed to everyone's deserving and you know, who's got the most pressing needs. Often it's difficult to do that. When you have a lot of staff turnover, you can't sort of maintain those same kind of values, and it's also challenging when you have very diverse patient groups. And then when there was not access to information about withdrawal management, substance use, and addiction services. So as I mentioned earlier, nurses identified that the hospital had a harm reduction philosophy, and they all agreed their unit had a philosophy. They thought that harm reduction was organizational policies, but when we actually went to look for the policies, what we found was a policy that said zero tolerance for substance use, and there was no harm reduction policy found. And so nurses were actually left without guidance in terms of what they could actually do in terms of harm reduction. So, you know, one nurse described coming into a room when someone was about to inject, and she said, you know, she didn't know, can I give clean supplies? Can I, you know, provide safer injecting education? But in the end, she actually turned what we came to call turning a blind eye to substance use. In other words, not interfering, but also not seeing opportunities for education and opportunities to prevent actual harms. And so, you know, this has come up in a lot of research that I do. I do a lot of research in housing and shelters, is that often the way that harm reduction gets practiced is by turning a blind eye to substance use, which actually has unintended negative consequences. So what happened in this situation was that we, in the final policy forum, we brought this issue around the inconsistencies in policies and the lack of policies to the attention of the nursing managers. And to their absolute credit, they identified that, yes, this is a problem because we pride ourselves on caring for people who use drugs. And so in this organization, the philosophy of care and substance use policies have been rewritten and changed substantially. And there are now clear guidelines in terms of harm reduction policies, and things like nurses can exchange needles. They can provide you know, safe disposable boxes for people so that they're not left to cause harm to staff. So for people who use drugs, the hospital environment is often highly stigmatized and unsafe. This stigma is deeply embedded in healthcare systems and has often been produced by and reinforced by current drug policy. So cultural safety and creating safe spaces in healthcare draws our attention as to what is needed to create safer environments. In order to promote the use of to create safe spaces and the promotion of culturally safe care for people who use drugs, the outcome of this project was the development of 5 principles, which you see there. And these principles were developed collaboratively with SOLID and with our nursing advisory. And they include engaging people who use drugs and shaping the care that they and their peers receive. So that can be from asking the individual for whom you're caring to more formalized ways of inviting organizations or people who use drugs to speak to nurses in your unit or in your hospital. To recognize the history and policies that criminalize and stigmatize drug use. and to see that stigma is often a product of our current drug policy, and to recognize that trauma, anxiety, and stress are part of the experiences of people you may be caring for, and drug use may be actually a response as opposed to a problem. To recognize that distress is a consequence of structural violence and trauma, and that when people enter healthcare, they do not come immediately trusting that healthcare will be provided in a safe and respectful way. So to emphasize respect, trust, and relationship as priorities in the provision of culturally safe care, and to build a culture of respect and trust and safety by recognizing and challenging substance use policies that criminalize use, and to also promote harm reduction policies. Those 5 principles are outlined in a short bulletin, which we put together from this project. It's called Creating Culturally Safe Care, and you can find it online at www.carbc.ca. I really appreciate you taking the time to listen, and I believe we have about 20 minutes, and I'm hoping we can have a really rich set of really rich discussion, and I welcome your questions, because no time like the present do we need to address stigma in healthcare so that people feel safe to access healthcare, and and it's critical in terms of preventing overdose and other harms of substance use. Thank you.
Great. Thank you for your presentation, Dr. Pauly. Before we move on to the Q&A period, we'd like to ask that participants answer a couple of short survey questions about today's webinar. Great. So we're starting to see some activity there. Thank you.
This is very cool. You can get immediate feedback. And it's anonymous, which is good too.
Great. So the numbers are still rising. Maybe we'll keep that poll open just for another 10 seconds or so. And then I see we're putting up the next question too, about how, if you're attending the webinar with others, how many people are there attending with you? Great. So thank you to everyone who's participating in the poll. It helps us to see the feedback and to know how many people are attending and how useful you're finding the information. And Dr. Pauly, thank you again for the presentation. So we'll now start the discussion portion of the webinar. And if you haven't already, please type your questions into the Q&A box that you see on the right of the slide. Okay. So to begin with, we have some questions from when people had registered as well. So Dr. Pauly, are there any guidelines or recommendations regarding accommodating long-term care residents, illicit drug use in residents' long-term care rooms? So if there's anything about resident care plans, including measures to reduce employee exposure exposure to sharps, but also harm reduction for the client.
This is a really great question about guidelines around substance use in long-term care, because I'm very aware that one of the issues is that oftentimes people who may have had a long history, for example, of homelessness or substance use may be housed in long-term care settings. And so To date, there are not any broad guidelines that have been written, but I can definitely point you to things like looking at some of the basic principles of harm reduction. And when it comes to actual policies related to substance use and harm reduction, the policies are actually often relatively straightforward in terms of being, providing people with a safe sharps container, providing people with clean supplies when they ask for it, which is actually a really important safety for staff as much as it is for the individual as well. In some of the other work that I'm doing, we're looking at managed alcohol programs, and there are, for people who have severe problems with alcohol use, and when they're hospitalized or they're in long-term care, there's a number of organizations that have actually developed protocols for alcohol administration in hospital and long-term care settings, and I'd be happy to provide you some contacts if that's helpful. Looks like we have lots of questions. Am I correct?
We do.
No, maybe not.
So thanks, Dr. Pauly. That also leads into, I don't know if there's anything you want to elaborate on in regards to harm reduction policies on acute care units, and how or if they would differ from what you had mentioned about long-term care facilities.
Yeah, that's a good question. I think the harm reduction policies on acute care units would be pretty similar. And, as I mentioned in the study we did, originally there was no harm reduction policy, even though people had adopted harm reduction as a philosophy. They were very focused on the fact that, we're preventing harms of substance use for people that come in. The actual policies had to be written and were written post this project. And so, that described both those principles of, kind of what's our goal and how do we treat people, but also those specifics of what do we actually provide. And I know that there's a fairly an important and lively conversation around providing supervised consumption services within hospitals as well, so that people aren't having to leave. And I can, there's a couple of programs across the country that are looking at providing a whole range of harm reduction services within hospitals, and so that would be in addition to, say, specific protocols that might be on a unit.
Great, thank you. And just keeping with the theme of settings, even though, understandably the principles are overarching and can apply to a variety of settings, we do have a question from a nurse who works in the north, and noting that community health nurses have significant autonomy in these kind of rural areas. So the question is if there are examples or guidelines regarding implementation of harm reduction strategies in these kind of remote healthcare clinics, namely needle exchange or crack pipes or managed alcohol programs. What do you have any examptions or strategies, or even can identify some challenges with those types of settings?
Yeah, that's a great question, because I think, those services would be integrated with many other services, which in many ways is actually a very ideal situation, because people often find with standalone services, they feel in a small community that if they go and access, something that's named the needle exchange, that they're then very vulnerable in their community. And so being able to access services that are integrated. There's a lot of guidelines available for the provision of harm reduction services, particularly needle exchange services. So depending on where you're located, the province of BC has, it's called
BC Harm Reduction Supplies and Services, which is a very well written out guideline. There's also one that was done for the province of Ontario. So those kinds of guidelines are really useful because they've been, developed over many years, and that's for needle exchange specifically. On other types of harm reduction services like supervised consumption and managed alcohol, supervised consumption services, there are, of course, lengthy protocols that have been developed, of course, by Insight. But there are also, now with supervised consumption sites being established across the country, many of them have developed protocols. And I'm not specifically aware of protocols that have been developed that would be specific to a rural or remote area. But given that, it might be worthwhile to look at the Dr. Peter Center guidelines in Vancouver, because they do offer supervised injection as part of an integrated healthcare service, and which would be more the type of model. And as of yet, we don't have any specific. There are a lot of protocols around managed alcohol that have been created by individual programs. And so particularly on those ones, I know most of those ones really well, so happy to provide resources. We also have, I should mention, we have a managed alcohol community of practice, which has a lot of resources on it as well if someone's interested more in the development of managed alcohol programs. And it's just on our Center for Addictions Research website. Thank you for the question.
Great, thank you. And so we have a question about the community again, but it's different, not specific to resources. It's more about policies around safety. So noting that oftentimes home health care policies, if the patient or family member has a history of substance use, and the patient, for this particular nurse writing in, notes that the patient has to come to the clinic, as that then minimizes a safety risk for the health professional entering the home. And we're just wondering if you have a comment on that, or anything to elaborate in terms of what, is there a need for a policy change, or what can you do to balance that safety of the healthcare professional with access to care for the individual?
Mm-hmm. I think I understand the question, and I'm going to repeat something that I said during the presentation. But I think, depending on the type of substance use, because, we're talking about, it could be alcohol, it could be injection, it could be smoking, could be the route. And so we have to think about the type of substance, we have to think about the type of route, and then we can think about, what are the particular harms. And so I'm just going to pick out for a moment injecting, and this is the one I mentioned in the presentation. So injection drug use, which means that if people don't have safe ways to dispose of needles, or they don't have safe access to needles, that's got harms for both the client and for the staff. And this is, some of the issues that have come up in many different settings is that when people don't have a way to safely dispose of supplies, they actually get left lying around, and that can cause a risk of needle stick injury to a provider. So it's actually what's safe for the client in terms of providing safe disposal and clean supplies is actually also safer for the staff. We can think about things like managed alcohol, the use of alcohol in severe alcohol use disorders, and for, when people are coming into hospital and if they're in the throes of withdrawal, I think all of us as nurses know what an unsafe situation that can be, or that people may be leaving hospitals. So if it's someone who's been on has a severe the managed alcohol programs are pretty specific for people with severe alcohol use disorders, and often combined with, other issues such as poverty and homelessness. But they're much, much, much safer for the client and for the provider to be implementing such things in settings where it's appropriate. And so I think part of it is when we implement harm reduction, it has to be implemented well, because I think when it's not implemented well, like, in the turning the blind eye example, that's when it actually isn't safe for anybody, or it creates unintended consequences. So, I really appreciate the earlier questions about protocols and guidelines, because although it's not, it's sometimes surprising how straightforward the guidelines, knowing how to do this is really important, because, frankly, we don't have a history of doing it in our healthcare settings, or we have in some and not in others. So really appreciate those questions.
Thank you. So this next question is about criminalization of drug policy. So, that criminalization is a product of drug policy. So before I get you to answer, Dr. Pauly, I did just want to mention that the Canadian Nurses Association has a discussion paper that does address this and some other harm reduction topics in greater detail. And actually, Dr. Pauly has been instrumental in authoring the first version of it in 2011. The 2011 version is currently on CNA's website, but we've been working for quite some time to revise this document, and an updated version that Dr. Pauly has also assisted with will be available mid to late June. So for people who want some more information about some of those concepts, please refer to that resource on our website. Dr. Pauly, I don't know if you would like to speak to expanding more on the statement that criminalization is a product of drug policy. I know that we have 4 minutes left, so I'm sure that it could be a longer discussion, but if you want to speak to it quickly.
Yeah, thank you. So currently we have drugs that are deemed illegal, and those substances, understanding the history of how those decisions were made is really important for nurses, because what it highlights is those decisions were not made based on pharmacological properties and harms. They were really made based on politics of morality and deeming certain things illegal as a way of furthering stigma and racism. And Susan Boyd's work is absolutely excellent on this and explaining this. And it's really something that we need, just as we need to understand, we need to understand our history of colonization in Canada and how that has played a role in producing, substance, or producing and contributing to patterns of substance use. We also need to understand how drug policy has driven harms like stigma, and how criminalizing substances really adds to that stigma that people are facing. And it really challenges, I think, each of us to really deeply reflect on our relationship with substances and how we understand substance use, as opposed to the story that we've been told by society about some drugs being illegal, and because they're illegal, they're therefore bad, and we criminalize people for them. And so I think that's a place where it should be part of our education and learning. So thank you for that really important question, and thank you to everyone who attended, and I really appreciate Canadian Nurses Association for the opportunity to share and discuss with you something that's very important in my world of work, and as I mentioned at the beginning, Jill, who would have been here if at all possible, something that she is very passionate about and believes in deeply to address stigma, to improve the care for people who use substances. Thank you.
Great. Well, thank you so much, Dr. Pauly, for your presentation and for bringing forward Jill's content as well, for creating safe spaces in healthcare for people who use drugs. We definitely hope that this session stimulated our audience's thinking about nursing practice and how to implement harm reduction and create safe spaces. And I've posted Dr. Pauly's contact information as well as mine if people have questions. There were a ton of questions we weren't able to get to. Hopefully you can find many of the resources people are looking for from the websites that Dr. Pauly mentioned or CNA's website as well. And this webinar will be archived, will be posted on our YouTube channel, which I'll mention briefly. So if you haven't already, please consider registering for the next webinar, Cannabis in Canada, Implications for Nursing in a Changing Legal and Healthcare Landscape. It'll be held on Tuesday, June 27th from 12 to 1 Eastern Time. And for those of you asking or wanting to share this presentation with colleagues, you can access recordings of our webinars and download your certificate of participation by visiting CNA's YouTube channel. And I just wanted to once again thank all of you for your participation today. Goodbye.
Goodbye.